The shoulder is made up of two main joints. One is the traditional ball and socket joint, which is the humerus, and the glenoid, the socket, as well as what's called the AC joint here, where the collarbone, the clavicle meets part of the scapula, the acromion. So that's known as the AC joint. There is a capsular lining around the shoulder made up of soft tissues and ligaments. These are important when people have shoulder dislocations. These are typically what tears. And also, this is what tightens up in what's called frozen shoulder when people get a very stiff shoulder. These are the main parts that stiffen up to prevent movement. There's also multiple areas of bursa, one main large one, which is the subdeltoid bursa you see there. This is what people complain of when they say, I have bursitis on my shoulder. That's where a lot of the inflammation comes in. This bursa is present in many joints, and it's basically considered a fluid-filled sac, or imagine a balloon filled with some water, and it helps things move smoothly, the muscles, the tendons, so that there's less friction. But when this is inflamed, you can see how, if you raised your arm here, that would pinch that bursa and cause pain, and that's called impingement. The rotator cuff, that's the kind of the workhorse of the shoulder. There are four main muscles, and we'll go over the function of each one. One is located in the front of the shoulder. There's one on top, and there are two in the back. So the subscapularis is the one in the front, and that controls internal rotation. You can see from the diagram on the bottom right, those are kind of the six main movements of the shoulder. The subscapularis does internal rotation to help press against the body or bring the arm in if you're pulling a car door in. The pec tendon of the chest also does that at the same time to assist in that. The supraspinatus really does a lot of work in the shoulder, especially in elevating the shoulder, in forward flexion or elevation. And it really works most from 0 to 30 or 0 to 60 here from your side up. And then once you get higher than 90, your deltoid muscle takes over to help keep it up elevated. And then the infraspinatus and the teres minor both work in external rotation, as you see in this bottom middle picture, kind of reaching out and away from your body. So what is shoulder arthritis? Shoulder arthritis is basically loss of cartilage and loss of joint space, as we see on X-ray imaging here. The left side showing you a clear space between the ball and the socket, and the right picture showing no space left, where that's bone to bone, and those two surfaces are rubbing against each other. And here's another picture from a different angle. You can see the big difference there, and then you get really large bone spurs that form on the bottom, sometimes known as the goat's beard here. And what happens is, as that shoulder or any joint really gets a lot of arthritis in it, you start to get stiffness that sets in, and you start to get more constant aching, especially with worse activity. As you can imagine, those two surfaces rubbing against each other, because the cartilage surface that's normally on there and is normally smooth and is normally thick has broken down and worn down, and the cartilage doesn't have any pain. But once you get to the bone, that's where people start to feel a lot of the pain. So what are some non-surgical alternatives? Well, there's a lifestyle modification, and that's changing how you work out, changing what activities you like to do. I saw a couple of gentlemen today that used to be electricians when they were working, and now that they've retired, some of that heavy work has caught up to them. And so there's exercise and physical therapy to help keep the shoulder muscle strong and to keep everything limber and moving. Anti-inflammatory medications such as Motrin or Aleve. And of course, this is all dependent on your own medical profile and what, having a conversation with your primary physician as well to see what medications are safe for you. Steroid or cortisone injections, which help relieve inflammation and pain. Joint fluid therapy, which we'll talk about, that's the hyaluronic acid, which acts as the lubricant. And regenerative medicine going into more of the stem cell type therapies. And we'll talk about several of those as well. So medication, as mentioned, heat and cold, and these can be variable. Most of the time for inflammation, we are recommending ice or cold packs, but you can see that in the morning, just to kind of get things limber and moving again. A lot of people like the heat, especially from a warm shower, to help kind of get blood flow to the joint and get it moving. Anti-inflammatories, are very helpful in reducing pain, but obviously they come with their own side effects. So overuse or taking too many of these can affect your kidneys. Some people have blood pressure reactions. And so, again, having a conversation with your doctor is very important before starting these medications. CBD oil and other various creams, these are coming into the new things that are out now, especially that, some of the laws in Michigan have changed. And it's non-intoxicating because you're not ingesting it. There's very little traces of the actual THC. But there's been some animal studies that have shown some pain relieving and anti-inflammatory properties. These have not really been validated in humans. It's very anecdotal. It's all kind of hearsay. It may work for one person and not another. How these things are made up have great variation. And so it's just another option that's kind of new to Michigan and becoming more popular nationally. And so, we bring it up as a treatment option. In terms of joint fluid therapy, just briefly to mention cortisone before I get to the hyaluronic acid. The cortisone is an anti-inflammatory. It's very potent. We put it into the joint under ultrasound guidance, and it works pretty quickly. 1 to 2 days, you should feel some relief. And our goal is that it lasts for anywhere from 3 to 6 months. We do recommend waiting 3 to 4 months between injections because too much cortisone in the joint can have a breakdown effect as well of hurting some of the tendon structure and cartilage structure if it's received too often and in too much of a dose. In relation to hyaluronic acid, it's seen in the knees, hips, shoulders. It's part of the naturally occurring synovial fluid, which helps to lubricate the joints. How does it work? Well, it binds to this interleukin 1B and inhibits this expression of this inflammatory marker. And this leads to a decrease in this metalloproteinase, which are MMPs. These MMPs cause further breakdown of the cartilage. So there's suppression of this by producing an anti-inflammatory effect. It also helps provide cushioning to absorb some of the pressure in the joints, and this would be in the knees or the shoulder, and to help absorb some of the vibration. It's also chondroprotective, and it reduces chondrocyte apoptosis. Apoptosis means cell death, so it helps reduce the cartilage cell death while increasing chondrocyte proliferation. And we want this to last, these therapeutic effects to last for up to 6 months. Insurance will approve these injections every 6 months. Now, most of the time, this is approved for the knees, and we're working on some insurances getting it approved for the shoulder. It is FDA approved as well. There's many different kinds, and these have evolved over time from 1 injection to 3 injections. Some are 5 injections. The differences between the brands are mostly in the structure of the molecule that they're injecting. And so the larger the size of this molecule, the more cushion you have between the cartilage surfaces. Wharton's jelly is also one of these newer types of injections. It comes from the umbilical cord tissue. You can see that in an umbilical cord you have the blood vessels, and then you have this substance, which is the Wharton's jelly, and it contains these primitive mesenchymal stem cells. We're going to talk about these a little bit later, but this Wharton's jelly has the highest concentration per milliliter of allogenic tissue. Allogenic tissue just means that it's coming from an outside source as opposed to autogenic, which is meaning your own tissue. And so these Wharton's jelly cells may be more effective than cells coming donated from adult tissue in the treatment of several conditions. And although safe, there's still more studies are required around this. It also contains high amounts of this extracellular matrix. These other components that are normally found in joints, in cartilage, that are gone when you start to get the breakdown in the arthritis. And that's the collagen, the hyaluronic acid, and these proteoglycans, which provide the water retention and the cushioning effect of synovial fluid. And there's been some studies to see, why this works. When you compare Wharton's jelly to PRP or bone marrow, those lack the hyaluronic acid. You can see these multiple growth factors uncovered in this study. And again, these growth factors help to, stimulate a kind of build up environment as opposed to the breakdown environment that is normally found in an arthritic joint. Again, you can see that through this study, they found that there was a 1.3 times higher concentration of the exosomes in the amniotic fluid compared to the bone marrow. PRP, this is the platelet-rich plasma. This also contains a large amount of growth factors, which can be taken from your blood and spun down and injected locally into an area. And this could be into a site of rotator cuff pathology of the shoulder. It could be to the site of arthritis. And again, it's promoting this anabolic or building up effect to support healing and to stop breakdown by blocking those metalloproteinase enzymes. So what does PRP contain? You can see it's this whole kind of slew of growth factors and proteins. And honestly, we've uncovered a lot of what these things do, but we don't know what all of them do or how they act in this to help promote pain relief and regeneration. So there are some of these things such as the Wharton jelly, the PRP and the bone marrow, which are not covered by insurance. Unfortunately, they're still considered experimental. But you can see that they do have, can expedite a healing process. These are all using your own body and your own tissue to heal. They can all be done in the office, so you don't have the risks of surgery, you don't have risk of anesthesia, and you don't have to miss any time away from work. Again, how does this work? Much in the same way as the hyaluronic acid. We're getting chondrocyte proliferation, proteoglycan synthesis, stem cell recruitment. So there's no actual cells in the PRP, but its job is to recruit the cells to the location of the injury, and also importantly, inhibiting the pain pathway. So the most common thing that we see is that patients complain of pain relief from these injections. It might not be giving you a brand new joint, but the pain and the function improve. And so how do we sort this out? You have the PRP, which is basically a small blood draw in the office. We put it into a centrifuge, and then it comes up with this type of, picture where the blood starts to get separated with the red cells, the white cells, and then the plasma layer. And that is, through this syringe system, what we end up injecting. And usually it's anywhere from 4 to 5 cc's that we inject using ultrasound guidance. Again, it's expanding literature every year. There's more and more research and papers that come out, but there's essentially no side effects. The best benefit they saw with arthritis was doing 3 injections, which were spaced 3 weeks apart. And this lasted anywhere from 6 to 12 months. When they compared it to hyaluronic acid, they did see superior results through our 3 different randomized trials. And so hopefully as we get more and more of these level 1 evidence, we'll be able to present that to insurance companies, and they'll be able to approve it as part of the plan. Again, like I mentioned, it does not contain stem cells, but it can direct those cells that are upregulated after injection to help regulate together with other mesenchymal cells. Bone marrow aspirate is another type of regenerative injection. It has been shown to contain more growth factors and up to 3 times more nucleated cells than PRP, but it is slightly more painful as we do have to put this trocar into the bone marrow. Usually we're combining these types of injections or this procedure during an arthroscopy of the joint, whether that's the knee or the shoulder. If we're doing some other procedure, the patient's already under anesthesia, it makes it easier to do this procedure. So these mesenchymal stem cells can help orchestrate differentiation of other cells. And so you get this multipotent cell, which when it reacts to other cells or in the right environment, can help turn into bone or cartilage or other connective or adipose tissue. Of all the types, in my personal opinion, I think the adipose tissue, when we're using that, has kind of the most, I guess, bang for your buck here. There's, more reparative cells than bone marrow. There's, more reparative cells than amniotic fluid, and certainly more than the peripheral blood. And again, this is using your own tissue. We're not manipulating this in any way, which is against, FDA regulations. There are some stem cell centers that will tell you they'll take your cells or your fat, they'll send it out and manipulate it and then bring it back. And that's really not following the FDA guidelines. Fat is a solid structure and it contains more than just the cells. It contains the blood vessels and the perivascular network. It contains some of the nutrients already present, some of the collagen. And this is very important. It's also a thicker tissue, and so it tends to stay where you put it. This is one of the founding fathers of these mesenchymal cells. Again, showing you how when placed in the right environment, these cells can differentiate to help reduce inflammation, fight cell death, and self-replicate. And they originate from perivascular structures, of which when we're harvesting the fat, and I'll show you that in a second, the key point of that is we still maintain the structure of some of these blood vessels, which are highly concentrated in fat and contain these perivascular cells and the mesenchymal stem cells. So again, just showing you kind of how these act, anti-apoptotic, anti-scarring, and fat has been used in plastic surgery for many, many years as a space filler, as a source of this kind of nutrients. And so transferring it to the orthopedic environment it is not that big of a stretch. And so if you think of why it's so good, think of how you get your plants or grass to grow well. You have the seeds, you have the soil, and you have the fertilizer. And this is all found kind of in that structure of the fat. And so it's a closed system, which is also, again, in relation to FDA and safety, why this is kind of the most popular system that we use, which is the lipogem system here. And so what we're doing is, as we harvest the fat from the body, we're taking it from larger pieces into a more smaller structure, which is easier to inject and allows it to act. So, you got to be careful about who you use this in. Certainly anybody with a systemic infection, with any autoimmune disease, anybody being treated for malignancy or blood-borne disease, people who are allergic to lidocaine cannot have this procedure. So, it's important to hear this and to kind of repeat it, again, because there's you don't want to fall kind of for the snake oil message or kind of getting scammed. And there's a lot of scams out there in relation to these stem cells. We're not promoting this as a, magical curing a stem cell. We're making sure that we use the language as these are mesenchymal stem cells. They've already been differentiated down a pathway. And what we're doing is helping place them into another location in the right environment where they can start to heal and promote a anabolic environment to help reduce pain. So kind of this is what it ends up looking like here, but we'll show you how we take it. So imagine this is the belly here. So we place a blunt instrument just underneath the skin and into the fat area where you see these clusters, and we put a whole bunch of numbing medicine in there. And we let that sit for about 20 minutes, and that expands the tissue layer and separates some of the fat cells. And then we go and harvest it. And this is very, you know, at first when we started doing these, we thought this would be painful for folks, but because of all the anesthetic that we use, actually people have very little to no complaints of any abdominal pain from this. And so you see this is kind of all the fat that we get on the right side, and usually we're taking about 60 to 80 cc's of that. And then we're washing it through and breaking up all those large clusters of fat cells into small clusters. You can see how it comes out there in that video. It's still fairly thick, but it is able to kind of stay in one place when we inject it. And these are some of the research studies that they did. So VAS is the pain score. You can see how pre-op they were 10, and then after 6 months it was down to less than 3, and that effect kind of maintained after 2 years. Now there was a slight bump here, and then around that 6 to 8 week mark is when we think the cells are starting to kick in, and there may be a slight increase in pain or inflammation there. And if you see the quality of life scores, how that dramatically increased as well post-procedure. So we always suggest using your own cells, and that whether that's the PRP, the bone marrow, or the fat, and it just decreases some of the risk associated with using another source. If you compare, what are the advantages of stem cells versus surgery, and this is a study about knees, but it can compare to shoulders as well, where the pain is minimal, the recovery is minimal. There's really no chance of infection almost with these injections, no chance of blood clots or nerve injury. The cost is significantly less, although it is more out of pocket. But depending on when you do your knee or shoulder replacement, deductibles are increasing significantly as well, and those costs are adding up. But it's important to know that this may not be the end-all, be-all solution, but these are other modalities to use, either before it gets bad enough to want or need surgery, or as an alternative. So in regards to what's new in terms of surgical methods to help arthritis of the shoulder, arthroscopic debridement, very few indications for this. It has to be very mild arthritis. The arthritis has to really be on only one side of the joint, whether that's only the humerus or only the glenoid. It's not likely to stop it or reverse the progression, but may give some period of improved function or pain, thereby delaying the operation. Other kind of more advanced surgeries that have becoming more popular, still rare because of the indications, but this top right picture, that's the microfracture procedure, where we put holes in the bone. And the idea of that is to help stimulate some of the deep fat and the deep blood to come to the surface and help create a new cartilage layer. But we know that the cartilage layer is never this shiny, white, pearly layer like it used to be, but it becomes a cartilage that's not as strong or not as slippery that forms over that. And the thought of microfracture is similar to what we do with PRP or bone marrow, just in bringing those cells and those nutrients and growth factors to a specific area. In very young patients or with small areas of arthritis, we can actually take cartilage transplants and place them into the diseased area. This is a lot more successful in knees than it is in shoulders. But we're still learning about other methods that we can do for this. Humeral resurfacing helps preserve bone, usually for the younger patient. But if most of your arthritis or disease is on the humerus and the socket and the glenoid is still intact, we can do what's called a resurfacing to help create a smooth surface here and decrease pain. Total shoulder replacement looks like this, where we are replacing the whole head as well as the socket. It's technically demanding. Really, studies have shown that you want to be with a surgeon that does a fair amount per year, not someone who does 1 or 2 per year, because of the learning curve and the nuances involved with the surgery. But patients can recover in near normal motion. We're actually publishing a story about one of my patients that had both shoulders done, and now he's able to throw a ball with his grandson, something he never thought he could do 2 years ago. And that's really brings a lot of pleasure to our team that we were able to do that for him, and it's one of our success stories. The recovery is 1 day in the hospital, although I'll talk later about how we're transitioning these surgeries to outpatient procedures. A sling is worn for about 3 to 6 weeks, and that's because during the surgery, we are taking off part of the muscle in front of the shoulder and then having to repair that. And we want to protect that repair and let it heal before we advance to more aggressive therapy and activity. But typically, we're having people golf anywhere from 3 to 5 months, at least starting with some putting and advancing the swing around that 5-month period. Newer technologies, before this is the socket side, you can see it's curved and dished. And these used to be metal backed, and we found that those were not good. We now have newer implants where we get better ingrowth of bone in between kind of these plastic rings. And you can kind of see some of the, we can detect the metal, detect better loosening qualities is how this has changed. Preoperative planning, this is a tool that I'm using more and more often. This is based off of CT imaging of the shoulder, and this is all covered by insurance, where we developed custom specific guides, and these are just different companies, but these help direct placement of the implant, and you can see this kind of red line, the pin in the center of the implant to a specific area. And this also helps us in people with very severe arthritis, where they have so much loss of bone that doing the surgery in a normal way or putting a normal implant into it would not end up being successful. And so this has come a long way. Some of it is you looking at computer and robot in the middle of surgery to guide the pin placement, and some of it is done preoperatively. And we just used this 3 weeks ago on a patient. And this is what it looks like when we're in the office getting ready. You have a CAT scan that shows us where their arthritis pattern is, and we can kind of what's called template and put in our implants, and it tells us we can run this through a simulation, and it'll tell us how much motion the patient has gained or what areas they may be limited in, and then we can adjust from there. And so this software and this kind of technology is going to become more commonplace as we place more and more emphasis on precise placement of the implant to allow for longer and longer duration. The reverse shoulder replacement has been around for a while, but recently newer technologies have also in implant design have helped us. This is typically reserved for patients older than 70 or with patients who have severe muscle atrophy or rotator cuff tears. And this works by, as you can see, switching the ball in the socket. And so we're not relying on the rotator cuff for motion anymore, but we're relying on the deltoid to help elevate the arm. And remember when I told you the rotator cuff worked from here to here, from 0 to 30. When that muscle is gone, the arm can't lift. And by switching the mechanics of the shoulder here, we allow the deltoid muscle to work at a better angle, and that allows people to lift their arm. What we've been able to do now with people with severe arthritis is, have implants that are more bulky or offset in different directions. Again, for people with severe arthritis and bone loss, and we use some of this metal to make up for some of that bone, whereas we're not having to remove your own bone to create the new angle. We can augment it with these base plates, they're called. Stem length is also changing. Our stems are getting shorter and shorter, and we've come to realize that you don't have to have the stem placed into the shaft. That the primary kind of stress of the joint is in this metaphyseal area here, and so we're trying to preserve bone as much as we can, so that in case we had to come back for another operation, we do have more bone to work with. Of course, all of this is patient dependent. There are times when we went in planning for this implant and had to put this implant in based on the bone quality of the patient, or the status of the muscles and around the shoulder. And so more and more we're converting our procedures to outpatient surgery. We realized over time, especially with hips and knees, that the home is the safest place for the patient, especially in an era now with this pandemic, where the hospital isn't the safest place to be. And there's been certain criteria that have been developed for safely performing shoulder surgery. And why I like this is because, as opposed to the knees and hips that require a little bit more therapy in the beginning to get you moving, with just a shoulder surgery, you can get up and move around without any difficulty. We do certain pain pumps and pain blocks and pain injections inside the shoulder during surgery to help the patient. And this is very popular now at the Campbell Clinic and in Minnesota, and more we're starting to do these here in Michigan. So I want to thank you all for your attention. We're going to welcome some questions. It's a lot of material that we went over, especially in the kind of the regenerative medicine field, and going to the newer techniques of shoulder arthroplasty. Well, I think we covered a lot of that. Really, it's dependent on how much arthritis do you have, what functional goals are you looking for? Is it just simple pain relief? Are you looking for improved motion because you want to play tennis or golf? Are you a painter that's got bad arthritis and you need to keep working? So really, as you saw, a lot of those that I discussed, different options, it comes down to, where is your level of arthritis? How is your level of pain? And what are your functional goals? With our job as surgeons, obviously we love to do surgery. We can do any of these surgeries, but our ultimate goal is to help the patient improve their function and reduce their pain. So a very similar answer. I mean, it's really, we do the replacement when the patient is ready for it. We don't just treat the x-ray. There's some patients with very bad looking x-rays, but can get by pretty well. And there's some patients with, mild x-rays that it's really affecting their life. And so it's really a patient physician discussion as to when to proceed with surgery. There are times when we do force your hand a bit, because we don't want the arthritis to progress so much that it limits the types of implants and the surgery outcome is affected because of severe bone loss. And that's been proven throughout the literature that the amount of bone loss you have in the shoulder is directly related to your ultimate outcome and patient satisfaction. That's a very good question. I actually had a patient of mine earlier today who was doing, has some arthritis in a certain area of his shoulder, and he started to do some different bench pressing. And so that was affecting him. And so we discussed how to modify that. Instead of laying flat on your shoulder, we prefer you sit up a little bit and do more incline presses. We do want you to keep the shoulder moving. We don't want you to baby it because then that'll make it more stiff. But always listen to your body. You know, if playing tennis is your thing, but you can only get through one match because two matches is too. You know, your shoulder doesn't it really gets angry. Then you know you modify to one match for that day, or you go every other day. You know, so. Overhead and lifting things away from the body tend to get people in trouble. Always try to lift close to your body with any kind of rotator cuff injury or shoulder arthritis. That's kind of a more safe position. It brings the center of mass closer to the body. So I think those are some things that can help. You know, as long as you're spacing them out, again, then there's no literature or nothing to say that you have to stop getting cortisone shots. We just want to make sure that they are spaced out. You do want to get yearly x-rays to assess the progression of the arthritis and, you know, consider other alternatives if the cortisone is not working. The cortisone is nice. It's quick. It's relatively, you know, cheap, no cost. It's part of the office visit, and so as long as it's working, I think it's a reasonable option. That's a good question, and ultimately depends on how much arthritis we see inside the joint and how effective we are at getting rid of some of the bone spurs. The problem with doing scopes on arthritis is that those bone spurs may be in hard to reach places, or that, you know, if you think about it, the bone spur is there to help relieve stress from the areas of the bone where the cartilage is missing. And so it's very likely that bone spur will come back. How fast it comes back is hard to predict. And so is it 6 months? Is it 2 years? You know, that part of it is hard to predict. The goal of doing a debridement is at least to assess the rotator cuff, assess the biceps, things outside of the arthritis that may be contributing to the pain, and to clean those parts up as well. And that's what gives people the majority of the pain relief, where it takes it from a high 8 level to a more manageable 2 or 3 level from the arthritis. So that's a great question. So obviously we're restricting you in the beginning, you know, as we protect some of the soft tissue repair, as we get the shoulder moving better. And it does take, you know, a good 6 to 10 months, sometimes up to a year, to really feel that you've regained your strength. Although you're active at 3 months and 5 months and 6 months, it may take a while to gain a lot of the strength back. And so, you know, there are patients that can go skiing. There's patients that you know, try to play some softball. The biggest thing is to be careful of any falling. That's the biggest thing that's going to get you into trouble, because if you fall, you can dislocate the implant, you can tear part of the rotator cuff, you can break the humerus around the implant. And so that's another reason we're trying to go to more stemless components. These are kind of the bad things that can happen, mostly related to falls. Certainly, if you slipped in the shower and you caught your arm on a railing, all those things can kind of get you in trouble. But we don't like to place limitations on people necessarily. We like to advance you as far as you can go. Some people, like I mentioned earlier, can get to a point where you're throwing a ball, and some may not, and that's just dependent on your kind of muscle function and how you recover from surgery. But if you're able to do it and you can do it safely, then we allow you to go. For arthritis itself, the X-ray is the best determinant of that. The MRI can help more with soft tissue pathology like the rotator cuff and the labrum. The MRI can tell us if you have any bony cysts that we may not see on X-ray, any bone edema, meaning softening of the bone related to the arthritis. That's where the MRI comes in more. But in terms of just plain old arthritis, the X-ray is the best for that. Now, if it's let's say a 40-year-old, I saw a 40-year-old today who had some narrowing of his joint on the X-ray. The ball and the socket were a little closer than they should be for a 40-year-old. I am sending him for an MRI because he may have a small area of arthritis that we may have to resurface or do a microfracture to help save that part and prevent it from becoming a worse case of arthritis. But once you're, in your late 50s, 60s, 70s, the X-ray is sufficient.